Good morning, everyone. I'm Dr. Marjorie Gass. I'm a member of the Board of Trustees of the International Menopause Society, and we welcome you to this session on breaking news. My co-chair, Dr. Meeta Singh, will be introducing the speakers, and we'll move right ahead. Since it's just 20 minutes a session, we'll try to take a couple questions after every speaker.
Hello, very good morning and a warm welcome. Thank you for being here. And I would like to call upon Dr. Sonia Cerdas to speak upon vitamin D, the controversy continues. It's a very interesting session of breaking news. The title is very catchy, and we have 3 diverse topics. So without much ado, may I call upon Dr. Sonia?
Good morning, all. It's a pleasure to be here, and I thanks for the organization to invite me to be here today. We will talk about controversies related with calcium and vitamin D, and these are my financial disclosure. I don't have any conflict of interest for the presentation that I will do today. As we know, calcium and vitamin D are extremely important for not only skeletal health, but for all the function of our organism. And there are a lot of controversies related calcium and vitamin D. And if we talk about controversies related with efficacy, we need to remember an old publication. This publication of Professor Chapuis in 1992 were clear. He demonstrated a significant reduce in hip fractures and non-vertebral fractures with the supplementation of calcium and vitamin D. But regarding efficacy, when we see this meta-analysis published by Reed in 2015, we can see that when you supplement the community with calcium, that is the first line of a result of this meta-analysis, we see that there is no effect in the reduction of hip fracture. And when you see the results with the supplementation of the combination of calcium and vitamin D in the community, again, the results are not significant. And only when you supplement calcium and vitamin D in patient living in institution, you see only in this group a reduction in hip risk fracture. And we have also data of efficacy coming from the WHI study, when more than 36,000 women were followed during 7 years with supplementation of 1,000 milligrams of calcium and 400 units of vitamin D. And again, we see non-significant reduction in hip fracture risk and only a modest but significant increase in bone density at the hip, and no cardiovascular increase risk in this study. We have also another important meta-analysis with 11 randomized control trials with vitamin D in patients with more than 65 years old, more than 1,000 participants, published in 2012. And in this meta-analysis, only high doses of vitamin D supplementations were related with a significant decrease in hip fractures and non-vertebral fractures. But when we see the details of this meta-analysis, again, significant results for hip fractures. I don't know if no, okay. For hip fractures and non-vertebral fractures in all the population that was analyzed, but who really received the more important benefit were patients, older patients with age more than 75, and also patients with who live in institutions, and patients who receive the combination of calcium and vitamin D. We have also old publication related vitamin D and reduction in falls with the intervention of supplemented patients with more than 800 units are related with reduction of 70% or more in the risk of falls. But the most controversies are seen around not only requirements, but about the supplementation of calcium and vitamin D. And in 2013, we had a publication of the U.S. Preventive Service Task Force regarding the indication of calcium and vitamin D supplementation. And at that time, they do not recommend calcium and vitamin D supplementation for the community, for general population. They put on the recommendation the importance to screen patients to identify patients at risk of osteoporosis, and at that time they recommend supplementation of vitamin D only for patients more than 65 years old to reduce falls. And also it is important to remember that these recommendations are recommendations not for secondary prevention. These are not recommendations for patients with osteoporosis or previous fracture, and these are not recommendations for patients with evident deficiency or insufficiency levels of vitamin D. These are recommendations for primary prevention and for general population. At the same time, there were, we have other publications the same year, 2013, by the IOF. They agree that in primary prevention is not recommended, is not effective to propose supplementation of calcium and vitamin D. They recommend supplementation of more than 800 units to prevent fractures and falls, and for patients more than 60 years old. At the same time in Europe, we had the same year similar recommendations, and in 2016, we have the IMS recommendation, where again, routine supplementation is not recommended, and routine dietary calcium supplementation cannot be justified in terms of efficacy, safety, and economic health, and calcium need to be obtained in their majority by the diet. And for vitamin D, again, supplementation is not recommended, and in some regions, we need to take in account that some regions, in some part of the year, supplementation may be individualized and may be needed. And if in one hand we have some problems really to argument in the relation of the efficacy, in the other hand, we need to not forget that supplementation is associated with some side effects. And we know about the GI side effects related with calcium supplementation. As you can see in this meta-analysis, calcium supplementation is significantly related with gastrointestinal side effects. And we know that high risk for kidney stone is related with low calcium intake, with high doses of calcium supplementation, and with vitamin D deficiency. And again, we have data from the WHI study, where in this study, they found a significant increase in kidney stones in patients who receive supplementation of calcium and vitamin D, as you can see in the slides. The other field of huge controversies are related of the cardiovascular safety. You remember many data from the group of Boland about the possibility of calcium supplementation vitamin D supplementation plus calcium with increase in cardiovascular disease and mortality. And you see here this meta-analysis from Lewis in 2015, where clearly there is no any relation, any significant increase in cardiovascular mortality, in all cause of mortality, as you see there, any relationship between calcium or the combination of calcium plus vitamin D supplementation with myocardial infarction, no relation with angina pectoris or acute coronary syndrome. And we have also this publication in 2014, the Cochrane Review, where again, vitamin alone do not prevent fractures. Vitamin plus calcium may prevent hip and other fractures, and a small increase in side effects regarding gastrointestinal and kidney problems, and no cardiovascular concern were the conclusion of this review. And recently this year, we had this publication from the England, where again, safety, cardiovascular safety were documented with the supplementation of calcium and vitamin D. And we think that in this field, we may be assured that, that there is a safety. The benefit of calcium supplementation has been shown only when the combination of calcium and vitamin D is done. And we have this nice review from Kano in Maturity this year. And we have also the publication that modest reduce in fracture risk is seen only, again, in individuals living in institutions. And probably many, many other publications repeat the same conclusions. We have also, at the end of the last year, an important meta-analysis with 33 randomized clinical trials and more than 51,000 participants from China. And again, they didn't find a benefit in calcium or vitamin D supplementation or the combination of them. Only in institution patients, the benefit, the slight benefit is observed. And they pointed out that probably only in this population, we may consider supplementation. And probably all of you saw the update of the U.S. Preventive Services Task Force this year, where again, general supplementation in calcium and vitamin D is not recommended for the general community because this lack of efficacy and slight side effects. And again, these recommendations are not for patients receiving osteoporotic treatment. These recommendations are only for the general community, for primary prevention, and not for secondary prevention, and not any concern about cardiovascular disease. Just to finish, you know that there are a lot of publication and a lot of controversies too related vitamin D and extraskeletal function. There are many publications regarding the possibility that vitamin D may be related in with benefits in cardiovascular disease. There are a lot of publications in relation of vitamin D as a modulator of inflammatory, immunological, and anti-oncological functions. And we saw a lot of publication, interesting publication, about extraskeletal function, related vitamin D deficiency and postpartum depression, related with vitamin D deficiency and more cardiovascular factor risk in metabolic syndrome, in relation with the bone health and in the preterm infant, and also vitamin D as a separate individual factor in relation with insulin resistance in prediabetes, obesity, and diabetes. And I think the controversy will continue until we have more evidence to work in these different fields. Just to finish, we can say that, again, calcium is essential for bone health, and calcium requirement must be obtained from diet. It is important to identify population at risk for fractures and falls, and in this population, we have to provide adequate calcium and vitamin D. Based on two large meta-analyses, vitamin D at the dose of 400 and 800 units with calcium, with the combination of calcium, appears to reduce fracture risk. And there is a small but a real risk of kidney stone with calcium supplementations. And the causal relationship between cardiovascular disease and calcium supplementation at today lack of scientific evidence, and based on data from randomized controlled trials, it is unlikely that calcium increases mortality. And finally, we need to remember that high doses of vitamin D increase risk of falls and fractures. And my last word is that we need to continue to read all the communications because the controversy continues. Thank you for your attention.
May I invite Dr. James Becker? And that's a very interesting topic, and I'm sure all of you are waiting to listen to that. Life Beyond WHI, Ethical Reporting of Data. All of us know that it's so crucial and it is so important. Reporting of data can change the health of the population that we have seen in the past 10 years.
Well, good morning, everyone. The topic that I was invited to speak about is Life Beyond WHI, Ethical Reporting of Data. And since we're going to talk a little bit about ethics this morning, it's doubly important that I show you my disclosures. Not particularly exciting. And what I'd like to focus on is a discussion of the government funding exemption that exists in some of the conflicts of interest declarations. And I'll explain this as I go on when we start talking a little bit about the ICMJE. Now, many of the examples I'll use come from the US, but if you look around the world, you can find examples almost anywhere. Just a little background thinking about ethics. Ethics is a moral philosophy. It's the formal study of behavior in which moral obligations are analyzed in terms of recognized methods. Medical decision-making has been dominated by a principle-based ethics. When we think of medical ethics, we know it goes back, way back, at least as far as Hippocrates. But today, we have academic centers, medical societies, medical journals, governments, and other groups defining what is medical ethics. Some of the classic values we're all familiar with: first, do no harm, act in the best interest of the patient. There are many issues in medical ethics, but among the most pressing is conflict of interest. If we wanted to define it, a conflict of interest occurs when an individual's or an organization's interests are in conflict with their professional obligations. The World Association of Medical Editors has said that conflicts of interest in medical publishing affects everyone with a stake in research integrity, including journals, research and academic institutions, funding agencies, the popular media, and the public. Simon Young wrote that personal profit does not have to be monetary. Profit can be related to achieving goals for the individual or for the organization. Goals can include acceptance of ideas, success of a journal, and many other things. There are benefits to authorship. Cameron noted the quantity and, to a lesser extent, the quality of authored publications have a lot to do with who gets promoted in academia, who gets tenured, and who gets jobs at prestigious universities. The World Association of Medical Editors said, competing interests can be associated with other sources of research funding, including government agencies, charities, which are not-for-profit organizations, and professional and civic organizations, which also have agendas that may be congruent or at odds with research findings. I did an editorial a couple of years ago on conflicts of interest in government-funded studies, in which I noted that there are significant benefits to authors and investigators in participating in government-funded research and to journals in publishing it, which include acceptance of ideas, prestige, academic promotion and tenure, speaking opportunities, funding, and so forth. There are substantial risks to patients in not considering the potential for conflict of interest. How often, I ask you, have there been publications from government-sponsored research in which no conflicts of interest were disclosed or financial disclosures included only industry sources of funding? Maybe I can help explain why. Let's take a moment and talk about the ICMJE, the International Committee of Medical Journal Editors. Now, they actually have a form which most journals use. It has an instruction page, and then you complete the form with your disclosures, okay? The vast majority of journals use this form. But the ICMJE itself, its membership is made up of 14 journals. Annals of Internal Medicine, BMJ, the Bulletin of the World Health Organization, a German medical journal, an Ethiopian Journal of Health Sciences, an Iranian journal, JAMA, a Korean journal, the New England Journal of Medicine, a New Zealand medical journal, PLOS Medicine, the Lancet, a Chilean medical journal, and a Danish medical journal. So in addition to them, there is representation on that committee from the U.S. National Library of Science and the World Association of Medical Editors. If you look at the form closely, under number 3, which is relevant financial activities outside the submitted work, it says in the instructions, public funding sources such as government agencies, charitable foundations, or academic institutions need not be disclosed. For example, if a government agency sponsored a study in which you have been involved and drugs were provided by a pharmaceutical company, you need only list the pharmaceutical company. This is the exemption that I am going to talk about. I'm going to give you 3 examples. The first is the WHI. Now, I don't intend to rehash the WHI in the couple of minutes I have. Bob Langer's already done a wonderful job of that at this meeting. However, I will make a couple of comments. One, the WHI initially was thought to cost over $600 million. Now I think many people think it's over $1 billion. This has provided funding to some individuals and institutions for approximately 2 decades. It has created many speaking opportunities and publications and created a favorable environment for academic promotion. Now, when I wrote my editorial a couple of years ago, some of the examples I used came from WHI, and it generated a rather rapid response to my editorial from some of the investigators in WHI. John Stevenson, sitting here, was kind enough to note their response, and he wrote a response to their response. And in it, he noted, quite interestingly, that under conflicts of interest, they wrote none disclosed. Let me spend a few minutes on on a deeper topic, since I think everybody in this room is familiar with WHI. Let me talk about the U.S. Preventive Services Task Force. And you heard from the previous speaker a recommendation which they had made. For those of you who don't know, as well as for those of you who do, the U.S. Preventive Services Task Force, or USPSTF, was first convened in 1984 by the U.S. Public Health Services. In 1998, it became sponsored by the Agency for Healthcare Research and Quality, AHRQ, which is in the U.S. Department of Health and Human Services. AHRQ says the following about the USPSTF. It conducts rigorous, impartial assessments of the scientific evidence for the effectiveness of a broad range of clinical preventive services, including screening, counseling, and preventive medications. Its recommendations are considered the gold standard for clinical preventive services. Now, if you go to the USPSTF website, they describe their membership. The U.S. Preventive Services Task Force is made up of 16 volunteer members who are nationally recognized experts in prevention, evidence-based medicine, and primary care. Their fields of practice and expertise include behavioral health, family medicine, geriatrics, internal medicine, pediatrics, obstetrics and gynecology, and nursing. The panel is